This is Introductory to Pharmacy Practice Experience number 4. Today we're going to do a lecture on nausea, vomiting, and antiemetics. The objectives are as followed. We're going to do these in no particular order, but we are going to conduct patient interviews to obtain patient information. We're going to conduct physical assessments, evaluate appropriateness of current medication, assess patient health literacy and compliance, interpret and evaluate patient information, and identify patient-specific factors that affect health, pharmacotherapy, and/or disease state management. Nausea and vomiting, I'm pretty sure everyone is familiar with these two terms. It's probably the most pronounced side effect in the history of pharmacy. Also, probably everyone has experienced this at least once or twice in their lives, or know someone who has. But starting off with the definition, you have emesis. It's just the act or instance of vomiting, and it's usually measured by the number of retching episodes. And retching is just the actual physical attempt that your body makes to vomit. Okay, that doesn't mean anything will be expelled, but it just means the actual attempt, the actual contraction that occurs. And the nausea is the patient's perception that the vomiting may occur. If you look to the right column, you'll see a whole list of different accompanying symptoms, starting with anorexia and ending with headache or neurological impairment. If you can remember from previous lecture in the fall, I said if you see a side effect of nausea and vomiting, it will be safe to understand that a patient may be suffering from anorexia also. Now, this isn't the same type of anorexia seen when people are having eating disorders, but it is a type of anorexia associated with the actual symptom of nausea and vomiting. So if you think about it from a practical standpoint, a person who is suffering from nausea and vomiting may not want to eat very much. And if they don't want to eat very much, then that could lead to them losing weight, being anorexic, and being malnourished, etc. Also, if you go down a little bit more, you see early satiety. That just means, that word just means full. So they get full pretty quick. So they may take 1 or 2 bites, and then in fear of causing a retching episode, they may hold back. Okay, and also if you look at it from the standpoint of difficulty swallowing, okay, a person who is expelling acidic stomach fluid can also harm the esophagus, so it may be harmful, may be painful, for them to actually swallow any kind of food. It's also important to understand that these accompanying symptoms, which will be discussed a little later in the lecture, but these are very important on cluing you in on different treatment approaches and outcomes. Okay, different accompanying symptoms indicate different causes of the nausea and vomiting, which is very, very important. So the patient interview is very important for you to understand. General symptom management. You want to make sure you maintain a calm environment with fresh air and avoid those strong, pungent perfumes or aromatic fragrances, or avoid the sights and smells of foods. Okay, most people know these things that can trigger these different retching episodes, and it's really individualized. You need to make sure you practice proper mouth care. Make sure that your mouth is clean, that is void of foods and different debris on your teeth and gums. Also, avoid greasy, warm, spicy foods, and make sure if you're going to eat, you can do small meals opposed to very large meals. Sometimes people overindulge in their meals and their drink, and it can cause nausea and vomiting. Also, drinking flat cola or sucking on ice cubes or bare frozen food. These things are done to soothe the stomach A lot of the carbohydrate content, especially in this flat cola, can actually soothe the stomach muscles so that you won't have some of the retching that occurs. Some general rules: you need to make sure you seek medical attention immediately if you suspect any type of poison has occurred as a causative agent for your nausea and vomiting. Okay, if you also have been vomiting for greater than 24 hours, also if you have blood in the vomit, that can be anything from upper GI bleeding or lower GI from ulcer, it can be from varices, it can even be a tumor. So it's very important that you seek medical attention if you do see any kind of blood in your actual vomit. Okay, also headache and stiff neck. These are important. These are important to note because those are signs and symptoms of a person who may have meningitis, especially when it's specifically associated with nausea and vomiting also. If you are going to seek some type of medical service, there are some examinations and tests that they can run on you. Generally they'll do a physical assessment where they'll look in your mouth, make sure you don't have any fungal infections. A lot of times people have fungal infections in their stomach. When they expel the contents, it progresses to their oral cavity. They also look at your nutritional status. Your nutritional status to see how malnourished you are. If you are malnourished, to see how much weight you may have lost. They also look at your degree of your dehydration and your renal function. Okay, so they'll look at your serum creatinine. Also, sodium potassium is always implicated in your hydration status. And then also your calcium, because a lot of people have hypercalcemia who are suffering from nausea and vomiting. Okay, so if you have this low volume of circulating blood and you're malnourished and dehydrated, your body's going to have a harder time excreting this calcium. Okay, they may also perform abdominal exams. They'll be looking for uh, surgical scars, liver enlargement, anything that they can relate to obstruction. Okay, and if you have bowel obstruction, any type of obstruction in your intestinal tract, it may warrant some type of surgery to correct. Treatment: there are different treatments available, of course. As far as the antiemetics, you have PO formulations of liquids, pills, and oral disintegrating tablets. You have transdermal patches. Also, you have rectal suppositories and IM and IV formulations. Your dopamine antagonists, like metoclopramide, haloperidol, those inhibit those central D2 receptors in your chemo trigger zone. So your D2 dopaminergic receptors are the ones in your chemo trigger zone that are responsible for your nausea and vomiting. These are good with agents, causative agents, particularly opioids, which cause nausea and vomiting, patients with hypercalcemia, and also patients with renal insufficiency. Another group of drugs is the prokinetic drugs. Some of these are metoclopramide, which I just mentioned before as a dopamine antagonist, and also erythromycin. Now, these drugs promote your gastric emptying by inhibiting your dopamine receptors in your stomach. Okay, and additionally, metoclopramide also stimulates the peripheral 5-HT4 serotonin receptors, which is going to increase or promote peristalsis. Okay, psychological techniques. A lot of times people have issues with nausea and vomiting because of stress or anxiety about it. They also can employ different techniques to reduce these sensations or feelings, these anticipatory sensations that they get about vomiting. Okay, a lot of times it can be guided by instruction from a psychologist the first time, and then thereafter it can be guided by a physician or nurse, or the patient can apply techniques themselves. But they usually try to employ some type of distraction technique or some type of relaxation technique. Also, some self hypnosis and music therapy has also been used. And as far as the surgery is concerned, surgery is usually implicated when a person has some type of intestinal or bowel obstruction. Potential harms. So here's a list of different drugs. It's not a comprehensive list, but here's a list of different agents that you use and some of the potential harms that have been noted in different trials. Okay, so if we look at some of these dopamine antagonists, we see a motif of this EPS, which is really prominent. Also, if we go to the 5-HT3 antagonist, we'll see headache, lightheadedness, and elevated liver enzymes. And especially with the Zofran, you'll see some QT prolongation. That was a recent finding in post-marketing surveillance. Okay, they also seen some vaginal itching or anal irritation with IV bolus corticosteroids, dexamethasone. Okay, and as far as antihistamine, we get some of the same classic anticholinergic side effects: sedation, dry mouth, blurred vision, dizziness, and urinary retention. Okay, and as far as your neurokinin 1 antagonist, you're going to get some elevated liver enzymes as a possible potential harmful effect. Okay, the patient interview. This is a very important concept you need to understand. I really need you guys to understand the pharmacist-patient relationship. First and foremost, you must understand the medication. You must understand the potential of past and current medications to cause some type of illness or some type of issue in a patient. So in this case, we're talking about nausea and vomiting, of course. Okay, but you can also assess the symptom itself. So the symptom of nausea and vomiting, you can look at its duration, its course, its frequency, severity. All of these things are very important for you to understand how to guide yourself to the next step in the process, which will be the treatment process. And what you have to do is you have to evaluate and integrate these ideas together as far as what you've learned previously from the patient, and that will allow you to triage and treat the patient. So when you're triaging the patient, you're really assessing the severity of it. So when you're addressing the severity, then that lets you know what type of treatment that you have to take. Is it a treatment that you have to give immediately, or is it something that can wait? These things are very, very important. Okay, interpreting and evaluating information. I want to start right here to let you know on the next slide, we're going to go over our algorithm in a little bit more in depth so you can get a better understanding of the actual patient interview, okay? But you have to understand that each category is going to give you information in regards to the possible causes of the particular problem, okay? And again, in this case, we're talking about nausea and vomiting. Okay, so you can look at the medications. The medications are going to give you clues. The symptoms are going to give you clues, and the physical assessment is going to give you clues. Once you have information that is gathered from either category, then you'll be able to make recommendations as far as treatment or some type of diagnostic confirmation or test for your route that you're trying to take. Okay, so we're going to look at this algorithm here. If you start at the top, you go to patient interview, then it goes to pharmacist evaluation of the following. And the first 3 tiers are going to be medication appropriateness, symptoms, and physical assessment. Okay, if we start in the medication appropriateness box, we'll see current treatment being used to address the issue, treatments tried in the past, and current new medications for other existing conditions. Okay, it's important to understand all 3 of those things. Okay, so if we look at current treatment being used to address the issue, the question is there a treatment being used to address the particular issue at hand? In this instance, we're talking about nausea and vomiting. So you need to know if it is. If there is a treatment being used, then you obviously know that it's not working. Okay. Then you need to look at the treatments used in the past. You don't want to have a patient on a treatment where they've had an allergy to a medication in the past, or they've had failure with that medication in the past. The patient's not going to have confidence in it, and they're not going to use it. And you can also look at the current and even new medications on their existing profile. You should be able to assess the potential for interactions, which may lead to the increase in nausea and vomiting. Okay, so you may have two drugs on the profile, and they interact with each other, and it may inhibit the excretion of one, thus increasing the concentration and increasing those potential side effects. Okay, that's why all of those things are important when you're talking about medication appropriateness. Okay, if we scramble on to the right, to the symptoms box, you need to look at things like the duration, the course, and the frequency, and the severity of these different types of symptoms, okay, and then even any associated symptoms, accompanying symptoms with those. And you need to look at the relationship with other factors like social behaviors. A person may be alcoholic, person may be a binge drinker. Maybe that's the reason why they are having some nausea and vomiting. Okay, mental status. As mentioned before, people have anxiety and they anticipate vomiting, so they have a lot of problems with nausea and vomiting from that standpoint, and they need to do psychological type of treatments. So the type, the duration, the course, any of those associated symptoms, relationship, all those things give you a clue on the different causes of the actual nausea and vomiting. That's a very important thing to understand. This information that you gather gives you an indication of possible causes. Just like when you're looking at the medication appropriateness, it's giving you an indication on possible causes. Okay, remember that. And also with physical assessment. Okay, so changes in physical appearance. Weight loss is definitely a quick example of, especially with nausea and vomiting. Okay, this will, being able to understand how to physically assess a person depending on the condition is very important. I remember a patient who was complaining of having nausea and vomiting problems for over 6 months, and they were taking an IV preparation of. No, I'm sorry, not an IV preparation, but an IM preparation of Phenergan. And I was trying to figure out how this person was not losing any weight, even though they continue to complain about the nausea and vomiting despite still taking the Phenergan. So, I know some people do actually abuse that medication. Okay. But if we drop down to the next tier, we're looking at important information needed for cause of issue and platform for diagnostic recommendations. Okay, so this is where we integrate these but integrate this information that we gathered from the previous tier. Okay, so if we start with we just use one of the examples here. It says vomit large amounts several hours after eating, accompanied with hiccups, indicates a delayed gastric emptying caused by partial obstruction of pylorus or duodenum. Okay, that's a lot of information that I'm sure none of us really know, but the point of that description is to show you the correlation between the symptoms and the possible diagnosis. So basically, it's like a differential diagnosis here. What you have to do is identify the links. Okay, I'm not interested in you understanding going through the pathophysiology to know that it causes it's from a delayed emptying of your gastric contents, okay? But you have to understand the link. So if you look at it, vomit large amounts several hours after eating, that has to do with the box right above it, the symptoms. It tells you about the frequency and the course and the duration of those particular symptoms. And also talks about any accompanying symptoms that are associated with it. In this case, it was hiccups. And then they give a possible, and then when it says the word indicates, they give a possible diagnosis for it. So once you get a possible diagnosis, then you have treatment that matches particular diagnosis. So different diagnoses, different situations, those are going to have different treatment protocols. Okay, so We can look at the next example on this box. It says concurrent use of digoxin, anticonvulsants, and theophylline may indicate a cause of nausea and vomiting. Thus, blood concentration should be drawn. Okay, so we can back our way back up to that medication appropriateness box, and we can look at, current / new medications other than existing for other existing conditions. That correlates directly with that. Okay, so if a person is taking digoxin, how does that correlate with a person with nausea and vomiting? Okay, well, I know that digoxin can cause nausea and vomiting because it's a common side effect when you're above the normal therapeutic levels. So what we need to do, we need to draw labs on that. Okay. So after we get that important information, we can go down to, triage and treat the patient. Basically, when you're triaging and treating, the link between that is to understand that there's going to be a point where you have to assess if the patient is going to needs immediate attention, or they can wait as far as the treatment is concerned. So do they need pharmacological treatment, or do they need surgery? And then you take into account different factors that can affect your pharmacology, like your population subgroups, health literacy, cultural differences, social behaviors, as we mentioned before, mental status, as we mentioned before. Okay, and once you decide to treat, you're going to have some different treatment outcomes that you're looking for. You're going to look at the rate of your symptom relief, their quality of life, and the side effects of those treatments are going to be some actual outcomes too. So what you should do is have supportive care measures in place for any kind of treatment. And then you need to provide information regarding causes, relevant factors, expected duration, potential risks, typical symptoms, and also consequences. Okay, now that we understand that, what we're going to do is we're going to basically extrapolate that information from the algorithm, and we're going to go through some other medications. Okay, so we're going to start off with the same example that we have in the actual algorithm. Okay, so if you can notice, medications are going to correlate with the medications box in that algorithm, and we just kind of condense some of the stuff down, and then the next level is going to correlate with that box that says important information needed for causes of the issue, and then recommendation box is just basically how you're going to treat them. But what you're doing is you're taking into all those things into account from that algorithm when you're doing this. So we start off again, current digoxin, anticonvulsant, or theophylline therapy. Okay, and if we interpret that, what do we know about that? We know that that's a common side effect associated with the toxicity of those particular agents. So what we need to do is we need to do a blood test for drug concentrations. Recommendation usually is to adjust the dose to a safe therapeutic range, or DC, or change the medications. Okay, so we're going to go through some other examples in the upcoming slides. I'm going to let you go through them yourselves because it's basically the same format, and I'll pick back up on audio when we get to the chemotherapeutic agents. Okay, so we're still in the medication box, okay? So what you have to do is you have to understand that these little scenarios or algorithms are in relation to nausea and vomiting. So if you didn't do that in the previous slides, you need to relate that first little line with nausea and vomiting. Okay, so we have chemotherapeutic. So if a patient comes and say, okay, I'm patient John, and I have chemotherapeutic agent A. Okay, now what do I know? What can I interpret and evaluate about that information in regards to nausea and vomiting? Well, specifically, I know that the chemotherapeutic agents possess emetogenic potentials. Okay, and there are 4 categories of the potential, so it can be high, moderate, low, or minimal. All right, so in this case, I highlighted high, so that's the route we're going to go for example purposes. Okay, and in that recommendation, they recommend you do a neurokinin 1 antagonist, 5-HT3 antagonist, and also a corticosteroid. The moderate, if I highlighted moderate, it would have been a different recommendation. And if I highlighted low, it would have been a different recommendation, and minimal, and so forth. Okay, so that's the point. You have to understand that there are certain clues, there are certain criteria, there are certain historical information that they gather to recommend certain things. Okay, so now we're going to go into a chart on the next few slides that go into more detail about the chemotherapeutic dosing. Okay, so now that we know the metagenic risk categories, we can look at this chart. Okay, if we start on the very left, it says high in the very top corner. So these are all the chemo drugs that have a high risk for nausea and vomiting. Okay, it's the one that has the least amount of drugs, but it actually has the most amount of drugs as far as the treatment is concerned. Because this group, you have to use 3 drugs. You have to use a 3-drug combo. And the cocktail is a neurokinin 1 antagonist with eprepitant, or you can use a 5-HT3 antagonist. There are 4 to choose from. There's really no difference in the efficacy between those. And also you can look at, you add on a corticosteroid, 12 milligrams of dexamethasone. If we shift to the right, to the very right, in the next column, you have the moderate group. You use 2-drug combination for this one, 5-HT3 antagonist and the corticosteroid. And then low, you just use a steroid. And then minimal risk, you don't use anything. Okay, so as you see, the treatment steps down as the actual metagenic potential steps down also. Okay, so 3 for high, 2 for moderate, 1 for low, and 0 for minimal. Okay, we've made it to the symptoms box, okay, on our algorithm. So we're in the middle now in the symptoms box. So let's just imagine a patient came and say, hey, I've been vomiting, I'm extremely thirsty, I've been urinating a lot, I'm constipated, I'm drowsy, and or confused. So how do we interpret and evaluate that information in relation to nausea and vomiting? Okay, so in relation to nausea and vomiting, we know that those symptoms correlate with a possible hypercalcemia and or hyponatremia. Okay, so what are the recommendations in this particular instance? Correct your calcium and sodium, and you can use a dopamine antagonist. Okay, so again, these slides will continue in this similar fashion, and in the next upcoming slides, we'll incorporate some aspects of the physical assessment along with the symptoms, and I'll pick back up on the slide that says refractory patients.